Good morning. This is Dr. Reeves, here to talk about anesthesia awareness. Um, Excellent. Okay, so what we're going to do in order to talk about awareness, we need to first define what is anesthesia. There are different types of anesthesia, and awareness, or the derivatives of those definitions, may or may not apply depending upon what type of anesthesia that is being performed. Second, we're going to talk about what is anesthesia awareness. Now, there are a couple of different definitions that are used in terms of describing anesthesia awareness, so we'll go into and answer those questions. And then we're going to go off onto to the twilight zone a little bit, talking about consciousness, because in terms of understanding what anesthesia is and what anesthesia awareness is, both of those definitions require an understanding of what is consciousness. And we have some classic definitions that we'll discuss today, but also we'll take a tiptoe into the quantum world and quantum mechanics, in terms of what does the advancements in quantum physics say about consciousness and its role in the universe that we live in. That's more so just to kind of expand our understanding of what consciousness is, as I believe that this will be coming more and more of a topic of discussion as we discover and learn more. Then we'll come back down to earth and talk a little bit about the ASA Closed Claim Project. We'll discuss what patients are at risk for anesthesia awareness, and then we'll talk about prevention. Well, the first thing, a topic, is what is anesthesia? Well, the goals of anesthesia typically are to render a patient in a state that they are able to tolerate a surgical stimulus without moving or remembering it or having a bad experience with it. That's ultimately kind of what anesthesia's goal really is. But there are different types of anesthesia. Anesthesia ranges from topical anesthesia, where you can put on some topical or a little local anesthesia on the skin to close up a skin laceration, to a little bit more like kind of a conscious sedation that you may have for a patient coming in for a heart catheterization or a minor procedure. And you have deeper anesthesia or deeper sedation, where for a patient that's a little bit more of invasive or a discomfort type procedure, such as an EGD or a colonoscopy. And then you have all the way down to general anesthesia. That the other term that we talk about is a MAC, right? MAC, and what that really is, a lot of times that term is not really used properly, but MAC is the minimum alveolar concentration. The textbook definition of MAC is where is the concentration, the minimum concentration of anesthetic agent required in the alveoli of the lungs, in which 50% of the patients or volunteers will not respond to a surgical stimulus. And so MAC is a general term to kind of get an idea of the depth of anesthesia. There are different factors that affect MAC. Young children, for example, there's two peaks for MAC requirements to fit that definition, where patients will not move. When they're babies, infants, and then like around the teenage years. Those two peaks occur where those two patient populations require more anesthesia, and then it gradually tapers off throughout age, so that as you age, you require less and less anesthesia to achieve the minimum alveolar concentration, or where 50% of the patients will not respond to a surgical stimulus. In the different types of levels of anesthesia, Awareness only really occurs or is only defined as occurring under general anesthesia. On all the other types of anesthesia, the sedations and that sort of thing, you're expected to have some kind of a recall because the intention is not to have complete amnesia, although most patients typically do with our current practices, which we'll talk about in a minute. So according to a couple of definitions here, well, what is anesthesia awareness? Well, anesthesia awareness is an incident during general anesthesia which may cause serious and potentially disabling psychological injury that can progress to post-traumatic stress disorder. According to the Anesthesia Awareness Registry, awareness is an unintentional consciousness or awareness of events happening during an operation, either with or without pain sensations. A person may be physically unable to notify the doctors or nurses of awareness during the surgery, but might be able to hear conversations, statements, and experience other sensations related to the operations. So when we're in that room and that patient's asleep and we're prepping and draping, or we're waking up and they have that tattoo, they may hear you. So be mindful of that. This has also been called recall during anesthesia and explicit awareness by some authors. If you are supposed to be awake or just sedated for surgery, it is not awareness during general anesthesia. Awareness is expected to occur at these times. And that's what we were talking about on the last slide. Well, another definition of anesthesia awareness is the explicit recall of sensory perceptions that occurs during general anesthesia, with a specific reference to explicit recall as a determining factor for anesthesia awareness. This definition is most appropriate for the adult population. Pediatric patients younger than 3 years of age do not experience explicit recall. Therefore, this definition may not fully apply to the pediatric population. Although this group may not experience explicit recall, they are still capable of experiencing anesthesia awareness. They may experience it in ways uncharacteristic to or different from the adult population. So those are the kind of big definitions of what awareness is. Essentially what it is having some sort of sensory remembrance during general anesthesia. Like you hear something, you feel something, any kind of the sense of smell, tasting, that sort of thing. Some kind of a sensory input that you're able to recall during the time when you're supposed to be unconscious. Well, that brings us to the question, what is consciousness? What do we think consciousness is? How do you know that you're awake? How do you know that you're aware? Is there a chemical pathway? Is there a neural pathway that defines consciousness and what consciousness is? How does anesthesia work? All these questions, really there are no good answers for, but there are a lot of really good theories. The thing about anesthesia is that we know that it works, but we don't know exactly how it works. There are some theories that there's a pathway in the brain called the reticular activating system that when we give the anesthetic induction agents such as propofol or etomidate or the volatile anesthetics such as sevoflurane, isoflurane, those sort of things, that what we do is we're disrupting the signal propagation along the reticular activating system, and somehow that disconnects the conscious pathways in the brain. But that's about the depth or the understanding of the definitions that we have now. So let's talk a little bit about the current classical definitions, and then we'll step off a little bit. We'll take a couple of steps down the rabbit hole and talking about consciousness. We won't go too far. According to the Anesthesia Awareness Registry, consciousness is a state in which patients are cognizant of their surroundings and this may occur regardless of cognition, memory, or high-order thought process. That means being cognizant, meaning that you're being aware of what's going on around you. And being aware of what's going on around you, you may not know that you're aware of what's going on around you, regardless of cognition. You may not remember what is going on around you, but you're still aware. Or you may not be able to analyze what's going on around you, but that means that you still have consciousness. You still are conscious. This definition of consciousness, I think, if you look at that and extend that to animals and insects and plants, they may have they may display awareness of their surroundings. They see a predator coming, and so they respond to that. That's awareness of their environment, of what's going on around them. The animal or the insect may remember that every time I go around this corner, there's that dog. So they may have memory, but they don't necessarily have high order thought process about what that thing is, or what that threat is, or what that condition in their environment is. But they still exhibit or display consciousness. So that's kind of how we look at this definition. Sensory perceptions are known as conscious recognition of sensory stimuli. I feel pain. I feel love. I feel joy. I see water. I feel thirsty. These are conscious conclusions of stimuli that your body, your physical body, is experiencing. And those stimuli, or the acknowledgement or the labeling of those stimuli, of those various stimuli, is conscious perception or conscious recognition of these stimuli, according to this definition. General anesthesia is a drug-induced loss of consciousness during which patients do not respond in a purposeful manner to any stimulus. So that time that you're in the OR and that patient's asleep and they are bovying somewhere and the patient moves and then the surgeon says, "Oh, the patient's awake, the patient's awake." They not necessarily are awake because it's not necessarily purposeful movement. Now, if they're bovying and that patient tries to reach down and grab the bovie, now that's a little bit different story. But if it's just kind of like an involuntary movement, that could just be a spinal arc. It could be direct muscular stimulation. It could be a lot of different things. But that patient isn't necessarily awake or conscious, according to this definition. And then also in reality, because a lot of times these patients don't recall or remember anything like that, but the perception of the surgeon may be that the patient is should be absolutely 100% perfectly still. Otherwise, they're wide awake, which is not really a clear understanding of what consciousness or awareness or anesthesia or any of these other physiologic pathways are. Now, let's go a little bit further down the rabbit hole in terms of defining consciousness. We talked in the previous definition, previous slides, about how consciousness is the cognizant recognition of your environment with memory, or with or without memory, with or without cognition, or with or without higher critical processing of whatever the stimuli is that's coming in. But when we take things on a different level, we have two different worlds that we live in reality. We have what is the classical world, that's the Newtonian world, the I dropped an apple and it falls to the ground world. I look to my left and I see a person, and I look to my right and I see another person world. I drive my car, I put on the brakes and it stops. That classical world, those general rules of physics and laws that we see every single day and understand every single day. It's called the classical world. But then we also exist or live in the quantum world. Now, what is the quantum world? What is that all about? Well, let's take a look at your hand, for example. If you look at your hand, you see that your hand is made up of, skin and blood vessels and muscles and tendons and different types of tissue. the tissue is made up of cells. Those cells have smaller subcellular compartments, like you have your mitochondria, you have your nucleus, you have your cytoplasmic reticulum, and all the different cellular parts that have their role and their function. Well, if you go down a little bit further and smaller, those cells are made up of molecules. Those molecules, maybe proteins or lipids or whatever it may be. And those molecules are then made up of individual atoms. And those atoms are comprised of electrons and protons and neutrons. And then if you go even smaller, a little bit further down the rabbit hole, you'll see that those atoms are made up of quantum particles, quarks, top quarks, bosons, all these kind of things make up a proton or a neutron. And if you keep going smaller and smaller and smaller down to the fundamental, basic nature of everything in existence, you come up with the Planck scale or the 0-point field. Now, we all have heard of Albert Einstein and E equals mc squared. E, energy, equals m, mass, times c, the speed of light, squared. The speed of light is a constant. It does not change. But according to this equation, energy and mass are exchangeable. They're the same thing. And some of the other laws of thermodynamics and other principles in physics state that energy can never be created nor destroyed. It only changes form. So going back to that definition of what we really are made up of, is we are really made up of pure energy. Energy on the level, when we go small enough, in the quantum world, we are made up of energy. We are just energy. E equals mc squared. Well, okay. What does that all mean and have to do with consciousness? Well, before we go into that a little bit, I'm going to have you watch a little bit of a video that kind of explains a little bit about the quantum world, just scratching the surface. So let's watch this video.
And here we are, the quantum weirdness, the infamous double-slit experiment. To understand this experiment, we first need to see how particles, or little balls of matter, act. If we randomly shoot a small object, say a marble, at the screen, we see a pattern on the back wall where they went through the slit and hit. Now, if we add a second slit, we would expect to see a second band duplicated to the right. Now, let's look at waves. The waves hit the slit and radiate out, striking the back wall with the most intensity directly in line with the slit. The line of brightness on the back screen shows that intensity. This is similar to the line the marbles make. But when we add the second slit, something different happens. If the top of one wave meets the bottom of another wave, they cancel each other out. So now there is an interference pattern on the back wall. Places where the two tops meet are the highest intensity, the bright lines, and where they cancel, there is nothing. So, when we throw things, that is, matter, through two slits, we get this, two bands of hits. And with waves, we get an interference pattern of many bands. Good so far. Now, let's go quantum. An electron is a tiny, tiny bit of matter, like a tiny marble. Let's fire a stream through one slit. It behaves just like the marble, a single band. So, if we shoot these tiny bits through two slits, we should get like the marbles, two bands. What? An interference pattern. We fired electrons, tiny bits of matter through. But we get a pattern like waves, not like little marbles. How? How could pieces of matter create an interference pattern like a wave? It doesn't make sense. But physicists are clever. They thought maybe those little balls are bouncing off each other and creating that pattern. So they decide to shoot electrons through one at a time. There is no way they could interfere with each other. But after an hour of this, the same interference pattern is seen to emerge. The conclusion is inescapable. The single electron leaves as a particle, becomes a wave of potentials, goes through both slits, and interferes with itself to hit the wall like a particle. But mathematically, it's even stranger. It goes through both slits, and it goes through neither. And it goes through just one, and it goes through just the other. All of these possibilities are in superposition with each other. But physicists were completely baffled by this. So they decided to peek and see which slit it actually goes through. They put a measuring device by one slit to see which one it went through and let it fly. But the quantum world is far more mysterious than they could have imagined. When they observed, the electron went back to behaving like a little marble. It produced a pattern of two bands, not an interference pattern of many. The very act of measuring or observing which slit it went through meant it only went through one, not both. The electron decided to act differently, as though it was aware it was being watched. And it was here that physicists stepped forever into the strange, never world of quantum events. What does matter? Marbles or waves? And waves of what? And what does an observer have to do with any of this? The observer collapsed the wave function simply by observing.
So in that video, as again, we're not going to go too deep into all of this and just kind of scratch the surface, but we talked about, before we watched this, about the classical versus the quantum world that we all live in. We kind of bridge the gap between those two. Well, where does consciousness arise from? Well, consciousness is like being the observer, being the measuring take. Also, all of our thoughts and our emotions and everything that we perceive of as being real originate from this quantum level. In that Planck scale, or that 0-point field, is where a thought or an emotion or a feeling or a perception kind of originates. Now, how does this work? Well, in a neuron, there's a small part of the neuron, right? The most fundamental part of a neuron. This is the pathway of how a thought of love, for example, originates. When you go down to a small part of the neuron, there's a part called the microtubules. There's these microtubules. On those microtubules, they have these proteins. And these proteins are these small proteins, and they are associated or adjacent to each other. And in between these proteins, there are electrons. And in that area, the electrons are in a field that has no charge. So they're able to freely float around in this space near these protons and these microtubules. When you think of the concept of love, for example, this thought, or this energy of this thought, originates from this 0-point field, or this Planck scale level, causing the electrons to move to one side or the other, or up or down, changing their position in response to the quantum side of the world. And what that then causes these proteins to do is they change their conformation. They either are in a open or a closed state. And then you have a number of these microtubules, these proteins reacting open, close, on, off, similar to how a circuit works or a computer works with ones and zeros. You know, the basic bit of a thought or of an action occurs at this level. On, off, on, off, on, off. And those things are propagated up into the microtubules, which then propagates up into the neuron, which allows you to generate a thought or a neural impulse, which is then propagated to a neural impulse, which then goes to a neural network, a neural pathway to different parts of the brain where memories are stored and that sort of thing, so that you get the concept of love or joy or pain. Okay? So that's kind of the bridge and the link between the quantum world and the classical world in terms of a thought. So what's next in all of this is that the concept of a thought, energy, movement, or anything kind of begins in this quantum world, and then it expands and extends into the classical world, but it originates from the zero-point field with this microtubule kind of pathway. Well, with this new understanding of what that is, potentially in the future we may have a better understanding or more precise understanding of what consciousness is and how consciousness works and what those pathways are and what those microtubules are associated with the perception of awareness or consciousness are or is, and maybe there would be some techniques, medications, or other processes that can be developed to more precisely turn on or off consciousness or awareness. There is a research group out of UCLA that is using different techniques to manipulate consciousness. There's a group out of UCLA that is using electromagnetism, or very strong levels of electromagnetism, to induce a state of anesthesia without medications, drugs, or anything. That's a lab that is doing some really interesting things, but we will come back down but I think that this is an area that we're going to be hearing more and more about as we go further and further into the future and learn more and more about our nature and the nature of our reality. So let's go into some discussion.
And here we are, the granddaddy of all quantum weirdness.
So,
the infamous double slit experiment. To understand this experiment, we first need to see how particles, or little balls of matter, act. If we randomly shoot a small object, say a marble, at the screen, we see a pattern on the back wall where they went through the slit and hit. Now, if we add a second slit, we would expect to see a second band duplicated to the right. Now, let's look at waves. The waves hit the slit and radiate out, striking the back wall with the most intensity directly in line with the slit. The line of brightness on the back screen shows that intensity. This is similar to the line the marbles make. But when we add the second slit, something different happens. If the top of one wave meets the bottom of another wave, they cancel each other out. So now there is an interference pattern on the back wall. Places where the two tops meet are the highest intensity, the bright lines, and where they cancel, there is nothing. So, when we throw things, that is,
occurs. Well, which patients are at risk for awareness? Well, patients who have received a low dose of anesthesia due to the patient's conditions. Patients with acute trauma or hypovolemia, where these patients can't tolerate a larger dose of anesthetic, otherwise they would compromise their blood pressure and other physiologic requirements or needs. C-section patients under general anesthesia, a lot of times these are crash emergency situations in which the baby needs to come out because it's in distress, and there may not be enough time to get the patient, the mother, fully unaware of what's going on, but also too because certain medications or processes that we do can cause damage to the baby, and we don't want to do that either. So those are another patient population that's at risk. Patients with impaired cardiovascular status, cardiac surgery patients, including off pump. Now, this used to be a higher rate of these patients because when the patient would be anesthetized, their blood would come out and go into the cardiac bypass machine. It would be filtered, and then when it came back in, the anesthetic agent was filtered out. But now they put vaporizers on the bypass machine so that they add anesthetic agent back to the patient's blood before it goes back into the body to help to decrease the state of awareness during bypass surgery. Other cases of patients who are at risk is some patients have an increased anesthetic requirements. Patients who are hitting the bottle really heavy, using other drugs, or you have red hair, you tend to have an increased requirement over and above some other patients. Younger patients, tobacco smoking, chronic use of benzodiazepines, opiates, amphetamines, or heavy alcohol are all risks of awareness. The other patients that are at risk is patients who have, this could be just anybody, if there's a malfunction or the anesthesia machine or delivery pump system is not working, the vaporizer is empty, the tubing has gotten disconnected, you have an infiltrated IV, you have a difficult intubation, you have a previous history of awareness, you have severe end-stage lung disease. If we're doing a general anesthetic, you have perfusion problems in the lung, you may have difficulty getting adequate levels of anesthesia in the blood. Obese patients, a lot of times you want to dose to the ideal body weight, but that may not be enough for severely obese patients. And the other category, which is total paralysis with muscle relaxation, that usually occurs from medication labeling error, labeling the syringe wrong. Well, in a root cause analysis of looking at kind of from the closed claim study of what the major causes were, most of them were low inspired volatile agent concentration, drug error, and unknown causes. Drug error usually led to the inadvertent paralysis of an awake patient. And then there were other category where patients that had no obvious causes, in the sense that there were so many things that could have been implicated in it that there was no one particular specific reason. Well, the incidence, how often does this happen? Well, the incidence of recall occurs in about 1 to 4 patients per 1,000 cases. At our institution, that probably is, maybe 1 to 3 patients a year, probably. Maybe less than that. Maybe 1 to 2 patients a year, according to that incidence, would be the national average. But however, the exact frequency or the exact rate at which this occurs is not really known, because a lot of patients who may be experiencing legitimate anesthesia recall don't necessarily discuss that with their healthcare providers. Sometimes patients have emotional or psychological problems from awareness that occur days to weeks after the surgery, and they don't exactly know where or why this has happened, but it can happen, it can appear down the road a little bit later. Well, what can we use in terms of prevention? Well, in the 90s, the BIS monitors and these brainwave monitors came out, and the theory behind those was that they have a little strip that goes on the forehead, and it monitors brain waves to assess and give information and feedback as to the depth of anesthesia that the patient is under. Right now, most of us are um, um, in a beta brainwave state. You're awake, you're alert, you're paying attention, you're listening. Those of you in the back are kind of drifting off and maybe nodding a little bit, maybe in an alpha or a low theta state, kind of that waking up or kind of falling asleep kind of area. It's in that waking up in that transitional area where a lot of hallucinations can occur, and those are called hypnagogic or hypnopompic hallucinations. And then when you're fully asleep and you're in your deep sleep, you're talking about delta. Okay, so these are the brainwave states, and the brain activity is measured by this BIS monitor, and it goes through an algorithm comprising a bunch of different things, and then it spits out a number. And supposedly, if you maintain a patient below 60 or 50, that they should have no awareness, and you should be able to titrate your anesthetic to those numbers. Well, in multiple studies and several studies that looked at this, it did not pan out and correlate totally to that effect. So it has not been, the BIS monitors and these brainwave monitors have not been recommended as being standard monitors such as pulse oximetry, end-tidal CO2, and the like, in terms of a monitor that to be used in anesthesia. The other recommendations from the Society for Prevention is talking to your anesthesia provider is the most beneficial way to help prevent awareness during general anesthesia. During the meeting, preoperatively, the patient should discuss their concerns and come up jointly with a technique that will be the safest and most effective treatment for these patients. But also it's important that these patients be honest with their anesthesia provider at the beginning and talk about lifestyle habits such as alcohol and drug use. Now, this is an area where I usually can get the truth out of somebody. I might say to them, hey, do you drink or do you use drugs? And they might say, oh, no, I don't. And I say, I don't really care if you do. I just want to make sure I give you enough so that you don't feel or remember anything. And then that's when oh, no, oh, I smoked crack last night. Something like that. That's kind of how you get the real truth out of patients, when you explain to them that by telling me the truth, I'm going to give you more. Okay, so now we finish up here with the discussion of the Closed Claims Project. The Closed Claim Project is a database consisting of adverse anesthesia outcomes, and it's the participation of about 37 liability insurance companies. And to date, they have over 8,000 claims in the database. And it was established back in 1985. Now, this database basically looks at all claims that were either settled or where judgments were rendered, to get an idea of what type of cases and claims are resulting in litigation victories for the patients and that sort of thing. So it gives you an idea of kind of where the lawsuits are actually happening, and so you can use this closed claim study to kind of guard your practice against situations or conditions that result in negative outcomes from a legal standpoint. So according to the closed claim study database, Anesthesia Awareness or Awareness of Anesthesia is only about 2% of all the total claims in the database. And of those claims, the most common cases are where patients have received low doses of alkaline anesthetics, or when there are medication errors, like labeling errors or mechanical problems, and so the patient was not able to receive an adequate depth of anesthesia, and so hence they had the resultant recall and traumatic events associated with it. Now, there was a time back at the beginning of anesthesia, about 150 years ago, when recall and being aware of what was going on during surgery was the norm. But medications, technology, techniques, and our understanding has gotten so much better that it is such a rare event nowadays, to the point to where we, as anesthesia providers, can no longer look at clinical experience to try to find ways to better treat or prevent awareness, because it doesn't happen enough. It does not happen enough for us to rely on clinical experience alone. And therefore, our understanding and our efforts to kind of minimize or eliminate this is based upon looking into large research studies, or kind of pushing the envelope in our understanding of consciousness and awareness and that sort of thing, in order to reduce the incidence even further than it already is. Well, this concludes the presentation. I thank you for your time. I hope this all worked out well enough, and I look forward to seeing you all soon.